Let's get 2 minutes on the clock and your time starts now. Peter Packer, a 30-year-old man, presents to your GP clinic complaining of increased episodes of facial flushing, loose stools 3 to 4 times per day, for the last 6 weeks. There's been shortness of breath on exertion that began a few months ago, and a new wheeze on breathing. He denies any chest pain, cough, fever, or nausea. He has no known allergies and takes no regular medications. He denies smoking or recreational drugs, drinks 1 glass of wine occasionally, and works as a chef in a busy restaurant. He denies any new exposures. His vital signs include temperature of 37 degrees, blood pressure of 130/80, pulse of 100 beats per minute, a respiratory rate of 20 breaths per minute, oxygen saturations of 96% on room air. There is obvious diffuse wheeze to auscultation, but air entry bilaterally. Examination of the oropharynx is unremarkable, but you do note a slight flushing of the face from the neck and above. There is no edema. Question 2.1. What serious diagnoses should you consider? List 4 specific diagnoses. Alright, time is up and let's get through to some answers here. So, this is a typical presentation for someone with a neuroendocrine tumour, in particular carcinoid syndrome. It's the facial flushing, the loose stools, the new wheeze on breathing. And so that is the big thing that I hope you've picked from this case here. Now, unfortunately, these kinds of diagnoses do often take a while to come through because they're often a bit more vague than this presentation here. There's often kind of preceding months of symptoms before a correct diagnosis is made. Of course, the other things you would want to be considering here could be an asthma exacerbation. So the carcinoid will get you 3 marks, asthma exacerbation get you 2 marks there, and it's that wheeze on breathing, the breathlessness. There's enough there to kind of tick through boxes, while less likely in this case, you're obviously going to want to be considering this as a differential. Now, this could also be a food allergy or intolerance, even though there's no known allergies and they state there's no new exposures. Working in a busy restaurant as a chef, who knows what they could come across. And there's enough of those kind of atopic kind of symptoms there that it would be another thing you would have to consider, of course, looking into that kind of anaphylactoid type reaction. Of course, this could also be something like cardiac failure. So again, enough boxes here to kind of tick some of those and would be a valid pathway to pursue. I've intentionally mentioned things like no edema to kind of push away from that a little bit as well. But I think, again, is one of the differentials for things like carcinoid. Chronic obstructive pulmonary disease, it says there's no smoking there, but again, being a chef, there's probably almost certainly going to be a lot of secondhand smoke from other chefs and other people working in that kitchen. So certainly something you would have to take into consideration. Now, these could also be things like gastrointestinal infection, and these are all going to be kind of lumped together here or grouped together. So we've got gastrointestinal infection, the time frames would be a bit iffy about that, parasitic infestation, giardiasis, Helicobacter pylori infection, and each of these things are often part of that investigative process when looking into potential carcinoid. And kind of on that similar front, but I think a separate type process, non-infective type process, so would not be grouped together with the previous ones. We'd be looking at things like inflammatory bowel disease, so Crohn's or ulcerative colitis, something in that kind of family there, also getting you a mark. So again, this is one of those cases that if you know it, if it's something you've read up on, fantastic, you're going to get those extra marks there. If it's something that you're not as comfortable or familiar with, still a way to get lots of different marks there, but just not as much as you may otherwise. Having a look here, we do have some answers in the chat here. So carcinoid, fantastic. Very happy to see that response in there. Poorly controlled asthma, excellent. Gastrointestinal infection, fantastic. And inflammatory bowel disease, well done. Very happy with those answers. Okay, now let's move on to the next section here. Next question. Let's get 2 minutes on the clock and your time starts now. Question 2.2. What investigations would help provide a definitive diagnosis? Select 4 investigations. A. 24-hour urinary 5-hydroxyindole acetic acid. B. Liver function tests. C. C-reactive protein. D. Serum chromogranin A-B. E. Chest X-ray. E. Full blood count. F. Coagulation studies. G. Erythrocyte sedimentation rate. H. Hemoglobin A1C. I. Urea and electrolytes. Alright, so let's get to those answers there. Time is up. And this is a case where there are going to be lots of marks available here. So again, if this isn't something you're as familiar with, RACGP do recommend a neuroendocrine tumour education course, which is available free through the website. I'll have the link through the notes below. Investigations here would be A, 24-hour urinary 5-hydroxyindole acetic acid. That would return a positive result in the setting of carcinoid. B, liver function tests. You'll see abnormal liver function if we do have liver involvement, as is often the case, sadly, with carcinoid. D, serum chromogranin A-B, or A or B. These would be expected to be elevated in the case of carcinoid. E, chest X-ray. In this setting here, not only is it helpful if there are metastases through to the chest, unfortunately may be the case, but it's also a matter of excluding a lot of those other differentials that we had there, things like asthma and COPD. So being able to tick that box away from those other diagnoses also makes it point more in the direction of carcinoid. Likewise with a full blood count, E, that's going to be worth a mark for that same thing. It's going to help push away from all of those infective causes there, and of course your urea and electrolytes, looking for abnormal kidney function and electrolyte imbalance. Electrolyte imbalance in this case would be particularly important given he's had that ongoing loose stools for 6 weeks. You'd be particularly concerned about massive electrolyte shift. Alright, hopefully everyone's happy with that. We do have some responses from chat, of course, and we've got guessing A and D, as it's the only ones I don't know anything about, and that raises a very interesting point there. Sometimes you'll come across questions like this, where you're like, I don't know what that is. It may be the answer. If you're looking at all the other answers there and thinking, well, it probably doesn't fit, you can always go on that hunch and say they've probably put that there for some fancy reason. Be aware, of course, there's always going to be the chance it's a red herring just to confuse you and make you think, maybe, and it may be unrelated. So always a risky approach, but hey, today it's paid off. Well done. The rest guesses C and E. C probably won't get you as many marks there, but E definitely does. That's the chest X-ray. Chest X-ray is pretty much a universal answer for most of these kinds of things. You can get so much information with a plain chest X-ray. More often than not, it's going to be worth a mark. All right, let's move on to question 3 then. Let's get 2 minutes on the clock and your time starts now. Question 2.3. You advise Peter that your suspected diagnosis has been confirmed and recommend he seek a specialist surgical intervention. But Peter lives rurally and no local surgeons have such specialist capacity. What barriers exist for rural Australians in accessing specialist healthcare? List 5 specific barriers. All right, time is up. Let's go to those answers. And this is one of those questions, if you've been hanging around on this live stream or watching this channel for long enough now, you're going to have seen this question pop up several times. I wonder why that might be. The RACGP love this kind of question here, so always good to have an idea of kind of templated answers you can slot in. So these answers in particular have been taken from the evidence base for additional investment in rural health in Australia, a recent report that was written with help from RACGP. And of course, the common things here are going to be geographic distance. So just being physically far away from healthcare is of course going to be a barrier. There's also going to be lower GP access for initial investigations or even those referrals once investigations have returned. There's going to be medical workforce shortages, including specialists in rural areas. There's going to be an uneven distribution of healthcare resources. We know that across the board, most healthcare resources are concentrated in city centres or large population centres. There's additional financial costs of service delivery. So supplying regional centres can be more expensive, and that's going to be a barrier for companies, for facilities to want to set up shop in a rural location. And tied into that as well, I think there's difficulties in attracting and retaining medical staff. Unless, and this is time and time again, and taking a little bit of a tangent from the question, this is something I'm quite passionate about and going to rant about, so hold on tight. We know that it's difficult if people don't want to be in the country to actually get them there. But we do know once people do get there, often they are happy to stay if they're provided with a good experience and good exposure, if they're made to feel like they're a valued member of the team in that setting. Unfortunately, it's really easy for anything to impact that, and so retaining medical staff is an ongoing problem. Unfortunately, there's no quick, easy solutions. It does take a lot of work. Moving back to the question then. So logistics and resource efficiency. We know that medical care is concentrated in city centres or large population centres. We know that there's financial costs of service delivery, so it goes hand in hand to say the logistics of and resource efficiency. If we're trying to use limited health resources to cover large populations, it does make the most sense logistically to have them where most of that population resides. Another one here is the perception of healthcare for rural Australians. There could be poor health literacy, so a poor understanding of what healthcare is, of what good health is, or even of what's normal and abnormal for their day-to-day life if they don't know or don't have an understanding of anything better. There could also be just limited support systems for rural patients. Time and time again where I am, I see patients unwilling or unable to go to a urban centre for specialist care because they either don't have the means to actually physically get themselves there, or they don't have a support network in that location to get them through what can be really, really difficult times. Hopefully that makes sense. We do, of course, have some answers coming in from the chat here. So, financial difficulties in affording health, definitely. There's a massive parity between socioeconomic status between urban and rural centres. Distance to travel to see specialists, definitely. Lack of reliable transportation, not in here, but would be tied into the logistics and resource efficiency. I think you would get marks from there, definitely. And more time required off work. An interesting one. I see what you mean, given they're more likely to have to travel further and make different accommodation arrangements. They're not going to be able to, duck into work at the end of the day kind of thing. I think you probably would get a mark for that one. It's a really good point. Wasn't in this list here. I think if you probably would see enough people put that down, they would probably add that to the rubric.